For our injury scenario for lab 4, posterior lower leg, we're going to have an athlete that presents with pain that's come on gradually, so no traumatic incident. And when we ask where the pain is, they point to the bottom of the foot towards the heel of the foot on the medial side of the foot. If we ask what happens, they'll say no specific incident. They've been doing a bit more running lately with the spring weather, and pains come on gradually over the last 6 weeks. So we can ask what type of pain. They say it starts out very dull and builds in intensity in the first 30 minutes of the run. If they walk for a bit, it feels a bit better, but if they start running, the pain comes right back again. Does the pain vary at all? So we mentioned how it gets worse with running. They report first thing in the morning, the pain is worst. So those first few steps that they take in the morning is quite painful, or if they've been sitting for any length of time. Rate the pain out of 10. So they put it at a 5 out of 10, and we want to know what is their 10 out of 10. We'll say they've fractured their thumb in the past, so that was the most painful injury that they've experienced before. What makes it better or worse? Better if they ice it. If they roll their foot on a tennis ball, that makes it feel a bit better. Worse, like they said already, those first few steps in the morning, or if they've been sitting for any length of time, going up on their tiptoes makes the pain worse as well. If they walk barefoot around the house, it's sore. If they wear flip-flops that have a bit of support through the arch, it tends to feel a lot better. Prior injuries, they wouldn't say that they've had any pain like this before, but they do report that they have tight calves and have for a long time. Medications, they've been taking some ibuprofen for the pain, and any allergies, no allergies at all. And then footwear, we want to ask them about their footwear. And they'll say that they found these shoes in the closet. They've never worn them running before, but they looked pretty good, so that's what they've been wearing for all the running that they've been doing. So maybe not the most appropriate shoes, and we know it's something that we're going to have to address as part of the treatment. So after our history, we move on to our assessment, and we always begin our assessment with our observation. Okay, so we'll have the athlete take their shoes, socks off. We're looking at their feet, and we would say that they have a bit of pes planus, or more flat feet, while they're standing. Now we want to put them through some functional movements and see if the shape of the foot changes at all. So we'll get them to walk out 10 steps and walk back towards us, our gait analysis, and we see some overpronation as they're walking, or the medial side of the arch is collapsing in. We'll ask them to go up on their tiptoes. They can do that. We'll do our knee to wall, and ankle dorsiflexion is equal side to side. We can have them do a squat, and again we see the medial arches collapse in and the tibias rotate a bit internally as they squat. And then right from our squat position, we'll do our twist test, and again we see some overpronation on both sides. After our observation, we're going to get into our range of motion. And we already did our weight-bearing range of motion with our tiptoes and knee to wall for weight-bearing plantar flexion and dorsiflexion. So we'll go into non-weight-bearing range of motion. And we start with our active range of motion first. So different movements that we want to check out. For ankle, we want to look at their dorsiflexion, plantar flexion, inversion, and eversion. And then for toes, we want to look at toe flexion and extension for first toe and 2 through 5. Okay, so for ankle movements, dorsiflexion is decreased slightly on the injured side with no pain. Plantar flexion is okay. Inversion, eversion is okay. For first toe, flexion is fine. Extension is decreased. And for toes 2 through 5, flexion is okay. And extension is okay. So that's active. After active range of motion, we do our passive range of motion. And when we do our passive range of motion, we get the same findings. So on the painful side, we find that their ankle dorsiflexion is still a bit decreased on that side, and we still find that first toe extension is decreased on that side as well. We'll talk about why those things are significant a bit later on. After passive range of motion, we move on to resisted range of motion or strength testing. So our RROM for resisted range of motion. And for our strength findings, for dorsiflexion, strength is 5 out of 5, no pain. Plantar flexion, we have 5 out of 5 and no pain. Inversion and eversion, all 5 out of 5, no pain. First toe flexion, we'll say is 5 out of 5, and they just had some very mild discomfort with that. First toe extension, 5 out of 5, no pain. Toes 2 through 5, flexion, 5 out of 5, and just some very mild pain. And extension, 5 out of 5, and no pain. So we found that ankle dorsiflexion was decreased, first toe extension was decreased, and strength was good for all our movements for ankle and the foot, but just a little bit of discomfort with big toe flexion and toes 2 through 5 flexion as well. Now, since this is a chronic, gradual onset injury, we're not concerned about a ligament sprain because that would be an acute traumatic injury. And that's also why we didn't ask if there was any snap or pop in the history at all. In terms of special tests, we noticed that ankle dorsiflexion was decreased, so we want to do our gastroc and soleus length test and see if one or both of those muscles are tight. And we saw first toe extension was decreased as well, so we want to do our flexor hallucis longus length test. So for special tests, we've got gastroc and soleus length test. And then our flexor hallucis longus length test as well. Now, for gastroc length test, remember gastroc crosses the back of the knee, so we need the we need the knee fully extended. That puts some stress or tension through the gastroc already, and then we passively dorsiflex the ankle. And again, we see decreased dorsiflexion on the injured side compared to the non-injured side. For soleus length test, now we need to bend the knee, and that will relax the gastroc, so the stress is primarily through the soleus. And when we do our passive dorsiflexion on each side with the knee bent, range of motion is equal. So we know it's primarily the gastroc that is tight, not the soleus. For flexor hallucis length test, we've essentially already done this when we did our passive toe range of motion. All we're doing is passively extending the big toe, and as we found earlier, first toe extension is decreased on the painful side. You'll think, well, what does this have to do with our injury? We can kind of give it away already that we're looking at plantar fasciitis or fat pad syndrome, given where their pain is. Well, remember, gastroc and soleus attaches to the calcaneus via the Achilles tendon. Well, there's some fascial connection between the Achilles tendon and the plantar fascia. So if gastroc and or soleus is tight, it can pass that tension down through to the plantar fascia. And here we found that our gastroc was tight on the painful side. For flexor hallucis longus length, if we can't fully extend the toe, our 65, 70 degrees that we need for normal walking and running gait, then that also is going to put increased stress through the plantar fascia. So we know we need to address both of those structures when we get to treatment. Last part of our assessment is palpation, and this is really the only thing that's going to help you distinguish whether it is plantar fasciitis or fat pad syndrome. So we palpate at the medial calcaneal tubercle where the plantar fascia originates from, and it's quite sore, so moderate pain. Our plus signs is pain, so 2 plus signs for moderate pain, and it reproduces the pain that they feel first thing in the morning when they walk on it. And we palpate along the length of the plantar fascia towards the metatarsal attachment, and they have mild pain along its entire length. If we palpate the calcaneal fat pad right underneath the calcaneus, it's okay. They have no pain whatsoever. So that's our big distinguishing feature between plantar fasciitis and fat pad syndrome. That and the pain first thing in the morning when they walk on it, or if they've been sitting for any length of time, that's characteristic of plantar fasciitis as well. So, diagnosis, plantar fasciitis. And then in terms of treatment, police, so there's going to be a period of rest. We're going to have them not completely non-weight bearing, but decreasing how much they're walking and putting stress through the tissues. They can ice, and that may be submerging the foot in an ice bucket, or taking a frozen water bottle and rolling and massaging their foot on top of it. They can roll their foot on a lacrosse ball or golf ball or some firm round surface to massage out the bottom of the foot. There's some stretches that they can do. We're certainly going to stretch our calf muscles, our gastroc, so traditional gastroc stretch, pushing into the wall, rolling out the gastroc with a foam roller or rolling pin. We're going to try and get deeper in on the flexor hallucis longus. We can do self stretches, pulling our toes up into extension, and especially the big toe up into extension to try and stretch out flexor hallucis longus. We want to strengthen the muscles of the calf, so isometric, isotonic, eccentric, but also our intrinsic muscles of the foot, so the small muscles of the foot that help support the arch. So our towel scrunches, grabbing on the towels with our toes, pulling it towards us, picking up marbles with our toes, standing on our feet, weight bearing, trying to create more of an arch structure by pulling the big toe back towards our calcaneus, and then getting people to try and maintain that higher arch position. That will force those muscles on the bottom of the foot to work harder. We can do that 2 feet, and then move on to single foot, and then we start challenging people's balance. So eyes open, eyes closed, maybe tossing a tennis ball up against the wall and catching it while we're standing on one foot. We definitely want to address their footwear. We learned that they're likely not wearing proper footwear for their runs. We saw from our observation when they're stationary and moving that the medial longitudinal arch is collapsing in, so they're having a bit more overpronation. so they need more support, and that would start with our Lodi arch tape job first. And if that's helpful, then we can recommend insoles for their shoes, maybe custom orthotics. If they only want support while they're running, then we can just send them out to get more supportive running shoes. But if they want support that they can switch between their casual shoes and work shoes and running shoes, then insoles is the better option, and they can switch them between their footwear. And then after we've worked on our stretching and our range of motion, strengthening our balance proprioception, we're going to gradually reintroduce them to running again, slowly building up the length of time and distance and terrain, following our FIT principles, so increasing each category no more than 10% per week. And that's it for our injury scenario for Lab 4.